welcome.
Oh, thank you, Jeanne. So I'm thrilled to be here, and actually I've come here to learn from you, so I'm really interested in learning more about what's going on here, and really want to make this more of a dialogue. So feel, free to interrupt me. I have tons of slides, but I've mostly put them on that I'll leave the slides here so that if people want them or want to look at them closer, they're available. I just came, the reason I'm in Scotland is I went to the ISEQH conference, the International Society for Quality of Care. Was anybody there? No. Well, it was fascinating. So anyway, there was a lot of presentations on what's going on in Scotland. And of course, we saw, the positive view. So I do have a little bit of background now to to kind of frame what I'm saying. The other thing that was interesting, though, is I've only gone to that conference once before. In 2009, it was in Dublin. And there I actually was presenting some of the work from the power study. So I haven't presented it in Scotland, but I have in Ireland. And surprisingly, there was nothing on the program around population health at all, health equity, like just a handful of presentations of people who had submitted stuff. And this year it was all over the program. So I'm hoping that we're getting to be a tipping point where people realize that population health and health equity is really key to improving health systems. So it was great to see that. So we were funded by the Ministry of Health and Long-Term Care of the province of Ontario. And what we did was we did really a comprehensive health equity report for the province of Ontario, and we looked at the leading causes of morbidity and mortality, and we published a series of reports that are all up on our website. But our real goal was not to produce a report that was going to sit on a shelf, but really to provide actionable data to help policymakers and providers both improve health and reduce inequities among the women and also the men of Ontario. And our overarching objective was really to use performance measurement and reporting as both a mechanism for knowledge translation and as a tool to drive equity in health and healthcare. And that really drove our approach to how we did the study, which was, I think, a little unique, and I'll talk about that. And we really wanted to provide evidence for use by a diverse group of stakeholders for use to improve women's and men's health in the province. And we did something. Do you talk about integrated knowledge translation here in Scotland?
We try to do it.
What?
In this group, we try to do it.
Ah, great. So we really took an integrated knowledge translation approach to this, and we learned a lot doing it. We were informed a lot by our partners, and I think it made it a better study, and I think it really helped with the dissemination and uptake. And I think one of the things we were successful in doing is really raising awareness of the magnitude of health inequities in Canada. I think you're very aware of them here in Scotland. I think in Canada people see themselves as being more of a fair and equitable society. And actually, when I started out, I was hoping to do some cross-national comparisons, putting the U.S. to shame against Canada, and when I looked at the data, I said, oops, I can't do that, because there were huge inequities. So I think you're probably all familiar with, definitions of equity in health, and my favorite definition is done by the International Society for Equity in Health, which just says it's the absence of systematic and potentially remediable differences in one or more aspects of health across multiple domains. And I like the word in there, remediable. There's things that you can do something about. But they went forward and further and divide equity in policy and actions, which is active policy decisions and programmatic actions directed at improving equity in health or reducing health inequities, and equity research, which is research to elucidate the genesis and characteristics of inequity in health for the purpose of identifying factors amenable to policy decisions. So I think, we've really raised globally, there's a lot of awareness about health inequities. You see the same curve whichever society you do them in. The magnitude varies across society, but where we are now, I think, with research is, what can we do to close those gaps? What are the effective interventions that will make a difference? So we used a comprehensive set of evidence-based indicators to look at gender and socioeconomic health inequities in order to identify opportunities for improvement and intervention, present objective evidence to inform priority setting, and provide a baseline from which to measure progress. And before we did this, surprisingly, nobody had done this in Ontario before, is look broadly over multiple indicators in terms of understanding the patterns of inequities. And these are some of our reports. We did HIV infection, reproductive gynecological health, diabetes, musculoskeletal disease. There's a whole host of them, and they're all available on our website. For those of you who don't want to read the whole report, we did little 8-page highlights documents for each of them, and you can download all of that. And this is just a list of the chapters we did. And in doing this, we actually ended up creating a new model for incorporating gender and equity analysis as an integral component of performance measurement and reporting. So, one of the things I do is I'm very, very involved in health system performance measurement, and equity is not always considered. And also using a community-engaged research approach in the context of a quantitative indicator report. And that really informed what we did. What we did that was unique is before we started measuring indicators, we went to the broad community. We went to community organizations diversely across the province. We held a series of roundtables, but all policymakers, decision makers, practitioners, and asked them, where are the gaps? What should we be measuring? And when we got our preliminary data back, we went back to these groups and said, does this resonate? And so we got context about our measures, which I think made our report much richer. And also it increased the uptake because people were part of the process. The other thing we did was we got some really interesting input. So when we looked at, and we know that data, secondary data can tell you a lot, but there's lots of gaps and there's a lot of things missing from it. And when we did our roundtables around access to care measures, people were very disappointed. We had limited measures of utilization, some survey measures. People said there's a lot more going on that are barriers to care for people, and you're not getting them. So as a result of that input, we actually did a qualitative metasynthesis of studies that were done across Ontario that looked at qualitative methods to look at barriers for a whole host of different populations: disabled women, immigrant women, low-income women, rural women. And we found there was actually a lot out there that nobody had pulled together. And actually that paper has been published. So, and we were able to use that context from the literature in interpreting the limited, quantitative indicators that we had. So I've become a big fan of mixed methods as a result of doing this work. And the other thing that we did, I think that was unique, was we included indicators that bridge population and public health and health care. I think one thing John doesn't know about me, I actually did 2 fellowships. One was in community and preventive medicine, and the other was in health outcomes research. So I've been, like, all my life trying to bridge these 2 worlds, and I think they're finally coming together. So there's lots of reports that look at public health and population health, and lots of reports that look at health systems, but they're very rarely put together on a continuum to look at a system of health that's aimed at really improving population health. This was not all my work. We had actually a huge team, and we had a very engaged advisory board that gave us lots of help. And as we go through, I'll tell you how they kind of strengthened the process. But we ended up with 60 investigators, and people really volunteered their time to become a part of this across different universities in Ontario. So I talked to you already a little bit about our roundtables. And before we started, we actually decided we wanted a framework to talk about, to look at our indicators. And in Canada, there's a CIHI health indicator framework, and we decided to build upon that. But we thought I think it was good in that it included all the different domains of health, but it was a laundry list. And so what we did was we moved it around into a pathway. And the other thing is there's a huge divide between people who do the social determinants of health, who say healthcare doesn't matter, and people who work on health systems quality. And the reality, I guess coming from personal experience, you can tell from my Brooklyn accent that I grew up in New York City. And I actually spent 10 years as a primary care doc in the public hospitals of New York City. And half of our patients didn't have health insurance. I went back to my old neighborhood to practice when I finished med school. And when you see what happens to people when they don't have access to care, you know how important, health care is. So basically our framework said the non-medical determinants of health are the primary drivers of health status. Nobody would disagree with that. But we can make that better or worse, right? So it's really health system characteristics and community characteristics, and ideally they should work together to minimize the impact of, the social determinants on health status while we work on, more global solutions to health inequities. And the other thing is that people talk about gender or sex being a determinant of health, but in reality, sex and gender affect everything. It determines your education, your social status, so we just pulled out sex and gender and showed how it interact with all the different dimensions. I think for the sake of time, I'm not going to go that detailed in our methods. You have the slide, but we used a rigorous modified Delphi process to select previously validated indicators that we could measure with existing Ontario data. And we stratified everything first by sex and then by income. I'll show you a little figure. Ethnicity and education as data allowed, and we did it at the provincial level. And it's coincidentally, Ontario also has 14 health regions. They're called LHINs, Local Health Integration Networks. I understand Scotland has 14 as well. So we have something in common. Anyway, the other thing we did, I think that was a little unique is, so there's work on women's health, there's work on inequities, but it's often also very separate. And what we did was we stratified all our indicators first by sex and then by the different demographic characteristics. And turned out to be really, really interesting, because it really showed how the social determinants affect men and women differently, and that there's different needs. But that also we really identified what are the needs for low-income men, and that it really, doing a gender analysis is beneficial for men as well as for women. So we had a whole host of products. We produced a comprehensive set of evidence-based indicators that many people, because of the way we structured the project, they're being used for health quality, Ontario for provincial reporting, they're being used by the health regions, they're being used by public health units, hospitals, community health centers. So we had wide, and we were very transparent. We sent people our SAS code if they wanted it. So we developed the indicators that are being used. We identified through a process a leading set of health equity indicators. So we've identified a core set of 27 indicators that span multiple domains that we thought could be moved and that could be tracked over time to foster equity. And I'll show you the list of the domains a little bit later. We have our reports, which we showed you. We have our highlights documents. We got supplemental funding to translate the highlights document into French, which was nice. We actually got a fair amount of traffic in the French. The other thing we did was, and this came from our advisory board, there was, we got funding and we started about a year after the LHINs were created in Ontario, and there was a lot of political nervousness that we were going to report publicly on the performance of the LHINs and what was going to happen when this data got out there. So we decided to frame it as, you were just created. We're going to report on the cards you were dealt, so that you know what you need to fix, rather than, blame. And the other thing we did is, before we released them publicly, we actually held a webinar for senior analysts and managers of the different health regions, where we released the results to them. And we said, if you want, we gave them their own spreadsheets. So they had their own data, and they were able to benchmark to the province. So I think that was very helpful in getting uptake and feeling like we weren't playing a blame game or something like that. We were doing it in a positive way. So we provided LHIN level data to the LHINs. Our website has gotten, I'll show you a slide later, amazing traffic. We've gone global. It's amazing now with the internet how people find you. And we've developed at the end, when we had a summary chapter that's also available on the web that kind of summarizes the findings from all the different chapters, and again with stakeholder involvement, we developed a 10-point health equity roadmap, which we think could be useful in achieving health equity. Of course, this is politics, this is the real world. When we started out, there was a government and a ministry that was very committed to equity. They had a cross-sectoral table. They were thinking about all different ways. They've moved on to cost and efficiency. So the uptake isn't there for some of the stuff as we hope, but we've gotten a lot of local uptake and use. So just a brief word about health indicator reporting is that it really can be an important tool to drive change. And it can be used, there's evidence of it being used to improve population health, improve access to quality and outcomes of care and healthcare services, and also around reducing health inequities. But I think there's an important caveat. There's some people that think that all you need to do is measure, give people a report card, and things will get better. That doesn't happen. So reporting by itself does not result in improvement. And for performance measurement and reporting to result in change, it needs to be evidence-based, strategy-driven, and linked to a commitment for change by health system leaders and providers, and also mechanisms for accountability. So I think that, reporting and indicators are a tool, but they need a whole other system around them really to affect change. And I just want to give two examples of three examples from a couple of papers. So this was a paper I really liked in 2007 by Phil Lee, that was in the New England Journal of Medicine, and he called it Eulogy for a Quality Measure. And the quality measure was use of beta blockers after MIs, and this is over 10 years in the US. And what's quite interesting is you can see when they started back in 1996, the mean was about 60%, but there was huge variation. So some hospitals, over 90%, were getting beta blockers, and some were down around 30, in the high 30s. So there was enormous variation in quality, and overall average quality wasn't that great, even though some people were doing well. Over 10 years, over 90% of everybody in every hospital reporting in the US was getting a beta blocker after MI. So, basically this measure was going to be retired. They've actually raised the bar. They want to make sure you're on your beta blocker 6 months after your MI now. So it shows how a national indicator can drive change. But another thing that's, I think, a little disappointing was it took 10 years for this to happen, right? It didn't happen overnight. But, and this is from another New England Journal paper from Amal Trivedi, who's at Harvard. But what she did was she looked at disparities over time in some of these nationally reported indicators. So over here is basically the percent of people with diabetes who got their LDL cholesterol checked. And this is the percentage of people who had it controlled after an MI or a coronary procedure. And so if you see here, and she looked and she stratified it by black versus white, because in the US there's a lot of racial disparities in care. So you can see that over a period of 4 years from 99 to 2003, the process measure was easy to fix. By the end of that time, blacks and whites were getting their blood drawn. You just, you make it routine to order the blood. But if you look at control, I think this is a really important point. It got better for whites, it got better for blacks, but the gap actually widened. And I think Jeanne has done related work, because actually they improved much quicker among whites and blacks. So it kind of highlighted the rules of the real need for stratifying indicators, and that if you look at the overall population indicators without stratifying for specific populations, you could miss important trends. This is a paper that I did way back when, where we had, before I came to, I did the work before I came to Canada, where we looked at a nationally representative sample of health plans in the US. And this is where we stratified first by sex and then by demographics, and here it was race. And this was lipid control for people with cardiovascular disease. And the blue square box is white men. The blue round circle is white women. The red square is black men, and the circle is black women who were much more disadvantaged and less likely to have their lipids controlled. So, I think this takes it the next step in the need not to just disaggregate by income, but also to look at, the intersection between income and ethnicity and education and income, etc. I'm going to skip some of this. The other thing is, people worry that if you start talking about, health behaviors and stuff, you're doing blaming. And it's income and poverty, and it's not health behaviors. We know that's not true. We know that health behaviors are one of the mechanisms that poverty, contributes to poor health, even though there's independent effects of poverty. And this is a nice conceptual framework that I really like that was done by Chloe Bird and Phyllis Riker, and it's called the concept of constrained choice. That basically you choose your health behaviors in the context that you live in. So people's choices are constrained, and probably one of the interventions that can be done is changing context to make it easier for people to make better choices. This is an old framework that I developed when I was a fellow at Dartmouth many years ago on access, quality, and outcomes of care, but it's kind of held up. And it divided access into primary, secondary, and tertiary access. And kind of showed how they need to be aligned to improve health outcomes. So primary access is, in the US it's having health insurance. People still can't get it right. It's tragic. I don't know why they can't figure out how to cover everybody in the country, but it's still not a reality and won't be in the near future. But also even in systems in universal coverage, there's transportation, trouble getting care. There's other barriers just entering the system. Secondary access is you might have a primary care provider, you have health insurance cover, but you can't get an appointment in a timely fashion, you can't get advice after hours, you can't get to see a specialist when you need one. So those are the secondary barriers to care. But the tertiary barriers are the link between access and quality, and this is where we get to caring for different, diverse populations. The provider is unaware, especially the elderly, of conditions and functional limitations, doesn't have the requisite knowledge and skills, that they need to be culturally competent. So there's a whole host of things, even if you get through your primary and secondary barriers, that you really need to address to I think, achieve health equity. Okay, so I'm going to show you, before I go on, I'm going to show you some of the results that we had. Does anybody have any questions or comments? Okay. So this says feeling poorly. Thank heaven, I thought you said you were feeling poor. Okay. So this was one of the first indicators we looked at, and it's, the SF1, self-rated health, and we also looked at self-rated mental health. And, you see the gradient, nothing surprising. But I think what was surprising for us that for both self-rated health and self-rated mental health, this is in Ontario, Canada, there's a threefold difference by income in the prevalence of fair or poor health or fair or poor mental health, which is huge. We saw the same gradient. When this is for women, we saw similar patterns for men for all the common chronic diseases. I'm sure you would see the same thing here in Scotland. This is not surprising to anybody. Hypertension, arthritis, back problems, COPD, diabetes, heart disease. It doesn't matter what you look at, you see the same pattern. And one of the things I'm very interested in is multimorbidity, because we know the same risk factors, we know environmental factors are risk factors for multiple chronic conditions. And so we looked at the prevalence of people who had 2 or more chronic conditions, and there's a couple of things I want to point out here. By the time people are age 65 and older, the whole population, men, women, independent of income, is likely to have, the majority have 2 or more chronic conditions. There is an income gradient, and if you look at, women are more likely to have multiple chronic conditions than men, and 70% of low-income women reported 2 or more chronic conditions. So the ones with the highest burden of illness have the least resources to really negotiate it. And also, even if you look at the working age population, 25 to 64, among low-income groups, 1/3 of women and over 1/4 of men have 2 or more chronic conditions. So there's a huge opportunity for prevention and also for redesigning I think the big implication here is that we really need systems of care that are patient-centered and not disease-specific, because most people have more than one. As a matter of fact, I've had the privilege this year of serving as a health and aging policy fellow in the US to kind of catch up with what's been going on there for the last 10 years. And one of the things I've been doing is working in the Office of the Assistant Secretary for Health on the multiple chronic condition strategy. So that's a great resource. They've done a lot of great work, and if people are interested, I can give a link to get information on that. We looked at disabilities, prevalence of ADLs and IADLs, women more likely than men to have any kind of disability, and by the time you get to age 65 and older, half of low-income women have some form of disability. And this is community living. This does not include people who are in long-term care facilities. But then when we looked at, so women get disabled, men die prematurely. And I thought this was quite shocking and quite a surprise. You know, an international indicator of inequity that's often used is premature mortality or death before age 75. And in the neighborhoods in Ontario with the lowest income quintile, 41% of men die before age 75. So this was pretty shocking. So I think this was one of the surprises of some of the work we did, was just how big and how much room there was for improvement. You look at health behaviors, you see the same thing. One of the things we did, I think, that was really interesting is we designed these maps to map health inequities. So this shows the percentage of people who, you know, were smokers. And we have the 14 health regions, and it's stratified both by sex and income. And if you look at it, if you look like up north, in some ways we're very similar to Scotland in that all the population is, you know, kind of concentrated in one geographic area. But Ontario is actually bigger than France geographically, and goes up way north to rural and remote areas. So there's huge, you know, there's huge geographic challenges in providing care. But if you look up here in the Northwest, 40% of, this is by education, 40% of women who hadn't finished high school were smoking. So that's huge rates, because, and this was, I think this had a fairly big impact, and there's a renewed vigor now around smoking cessation in the province, because Ontario had a very successful smoke-free Ontario strategy and had successfully reduced smoking rates. But until you started looking at different subpopulations, you realized that there were a whole host of people who had missed out on that. The other group that have huge rates of smoking was Aboriginal men and women. The rates were very, very high. So then we also looked at indicators of the social determinants of health. This is just the percent of households reporting low income, and just that there is an association with ethnicity and immigration that is not surprising, so that income is not equally distributed across groups. I'm going to skip that. And this is an old slide, because this is from the 2005 Canadian Health Survey. This was one of the first reports that we did, but looked at the percentage of people reporting food insecurity. So that's worrying about getting the adequate quantity or quality of food. 25%, 1 in 4 low-income Ontarians, and I'm sure it's much worse now, because with the economic crisis, there's you know, papers every day, you know, articles every day in the newspaper about runs on food banks and people really struggling to get food in a wealthy country like Canada. I think this was quite surprising. I actually advocated that the Ministry of Health should put food insecurity on their scorecard, because as a physician, I can't control somebody's diabetes if they can't get a healthy diet, and if they're buying a lot of, you know, low-cost starches, you know, refined carbohydrates. No matter what I do as a doctor, I'm not going to be successful. But they didn't buy it. So the other thing we did was we did some back of the envelope calculations to really try to hit home the impact. I think this is about communicating the relevance of some of the work we did. So what we did was we estimated if all Ontarians had the same health as Ontarians with higher incomes, there'd be over 318,000 fewer people in fair or poor health, almost 250,000 fewer people with disabilities, and over 3,000 fewer deaths a year. And I think one of the things that we came as a real take-home message of our work was that health equity is really key to health system sustainability. Because if you think about who are the biggest drivers of needs, use, and cost, are people who have the worst health. So until you tackle health inequities, you're not going to be able to really make a big dent in health system sustainability. The other thing we did was we looked at a lot of acute care indicators. So this is just a percentage of people who had an AMI who had got a prescription statins. If you can see, women are still a little less likely than men to get statins. There was actually no difference for beta blockers, ACE inhibitors, but absolutely no income gradient. And we found this for a lot of the acute care indicators, that there were just small, if any, differences around management of an AMI, management of stroke, cancer, acute cancer care. So the acute health system has been fairly, it works for people. That's not where the problems in the system.
Arlene, you might just want to tell people here who won't know that people over 65 have all their drugs, prescribed drugs free.
Yeah.
In this province. Not people under 65.
Yeah, and actually we did a very interesting paper on that, which I'll show you some slides. Yeah, so we don't have universal coverage for drugs and it has real implications for chronic disease management, which until you get to 65. We actually get, this was another thing, oral health is not covered either, and dental care, and like half of low-income Ontarians had not seen a dentist in the last year, and especially when we looked at the elderly, the rates, again, among low-income elders were really, really high, and if you think about how important that is, you know, oral care to nutrition and healthy aging. So this is, you foreshadowed me, John. So this is, unfortunately, I had them in a PC program and they didn't transfer over. So I'm just going to talk about these slides. So this paper was actually, and I shared it with Sarah, was in hi, who's done very similar work here in Scotland, where we looked at socioeconomic differences. We had 600,000 people that we followed over 6 years. And we looked at differences among diabetics in outcomes, for cardiovascular outcomes and all-cause mortality, so AMI, stroke, and all-cause mortality. And these are adjusted for age, sex, previous cardiovascular disease, diabetes duration, healthcare use, etc. So these are well adjusted. And again, you see the same gradient for all of the outcomes. The slide that couldn't copy, it just kept coming out black, and I don't know why, it was our forest plots, where we stratified by age. So we looked at those under 65 and those of over 65, and we actually did some, some fairly, a lot of sensitivity analysis, some spline analysis to make sure what we were seeing was true. But what we found was the income gap between rich and poor narrowed substantially just at age 65 in terms of these outcomes, and we hypothesized it was because of access to drugs, because if you're diabetic and you can't afford your drugs, it's going to be difficult to get good control. And we actually got good coverage on CBC for the need for pharmacare in the country, because we don't have a universal pharmacare as part of the Canadian health system. I guess drugs here are covered.
Long story.
Oh, okay, I have to find out
They
more
are
later.
now, yes, yeah.
Okay. And this is another one. These are adjusted analysis, and that we looked at income and amputation risk in men and women with diabetes. And if you can look at, this is where we really need to reach out to low-income men. So low-income women, the lowest income women had a slightly higher risk of amputation, and we also looked at major and minor amputations. But that's really a preventable cause of disability, and you think about what happens once somebody loses a leg and how it impacts upon their life, was another thing that we found. Do you track ambulatory care sensitive?
We're starting to. Has anybody in the room done it yet? We're about to do it.
Okay. So we looked at ambulatory care sensitive conditions for common, COPD, asthma, diabetes, and heart failure. But we also looked at depression, because if you think about it, good depression care in the community should also prevent admissions. And again, you see the same, the same gradient. It's kind of boring. women more likely than men for depression, but there's other conditions where men are more likely to be admitted. But this was quite interesting. Then one of the things that's recommended, it's actually recommended if you have a hospitalization for a major depression, that you be seen in 7 days. We were liberal, we gave it 30 days. And basically 2/3 of people only, there was a third of people who did not have a follow-up visit within a month of being discharged. And when we looked at this for AMI, it was 99%. When we looked at it for heart failure, it was 99%. So it really just highlighted the fragmentation of the mental health system and primary care. So I think a lot of our indicators, we tried to tell a story and we tried to highlight stuff that had implications, I think, for policy and for improvement. The other thing we looked at is the number of people who ended up back in the emergency room or readmitted, and it was just, you know, the people who are lost to follow-up. The other thing we did was, so we mapped this. This is the number of people who had a physician visit for depression after, you know, within 30 days, and you can see the geographic variation. And once you get, as you get out from the center of Toronto, which is probably overpopulated by psychiatrists and mental health professionals, it gets more and more difficult. This up here is around Ottawa, so that's, you know, fairly well. But you can see there's huge regional variations. And so there's a lot of work in Ontario around, you know, telemedicine to try to improve access to services. One of the things I'm interested in, I'm actually doing a pilot around integrated care for complex disadvantaged elders in the community with heart failure, was looking at heart failure. And again, you see the gradient. This time it's men more likely than women to be admitted. But this is something that people don't look at very much. We looked at this, the rates of hospitalization for heart failure by age and sex. And if you look at it, it's mostly people over 65 who are admitted for heart failure, and most of them, the highest rates are among those over 80. And again, a pie chart, over half of the admissions are people over 80 for heart failure in the province. And people don't think about that. When people start thinking about improving heart failure care, they think about the standard, you know, middle-aged person post-MI or, you know, with diabetes, and there's standard protocols, but these are complex people with multi-morbidity and probably, you know, difficult social solutions. The other thing I know in the States right now, 30-day readmissions is a big measure, and hospitals, there's actually financial incentives that are tied to it. So we looked at that in Ontario. Basically, within 30 days, about 20% are readmitted, so there's probably room to do better there. We also looked at the reason for readmission, which about a third was related to heart failure, about a third was other cardiovascular causes, so you came back with an MI or an arrhythmia, and about a third was totally on cardiac. So it just shows that unless you take a patient-centered approach to these people and deal with their multimorbidities and frailties, you're not going to, you know, optimize readmission rates. But the other thing we did was we looked at 1 year, and within 1 year, 60% were back. And the breakdown for reasons was very similar. But, you know, so I think there's a lot of focus now on reducing 30-day readmission rates, and people can feel really good. But unless you fix the care in the community, people will be back in 35 days or 40 days. And sort of the real need to transform the system to provide community care for chronically ill elders in the community. So the other thing we did was we did some back of the envelope calculations for these 4 conditions to say how many hospitalizations could we avoid if the lowest income had the same rate, if everybody has a high income, similar to what we did for disability. So there's about 52,000 admissions a year in Ontario for these 4 conditions alone. And what we calculated, the difference by income was about 16,000, which was 30%. So it's huge. There was also huge regional variation in admission rates, and we got the same exact thing when we looked by region. If all the regions could get the rates of the region with the lowest performance, about 30% of these admissions are probably avoidable. And clearly, you know, avoiding these admissions is both better chronic disease management in the community, but also prevention to, prevent the burden of some of these diseases in different populations. I think I'll go through the rest of this stuff quickly because I want to get to our roadmap at the end, but just that we looked at, I think important as Ontario has grown increasingly diverse, and I'm seeing more diversity in Scotland, the importance of looking at differences across different ethnic groups. And here it's, 45% of Aboriginal women report some kind of activity limitation. So there's huge disparities and huge differences among ethnic groups in terms of health status. And then we looked at basically in Ontario, francophones who don't speak English tend to be more disadvantaged. They also were more likely to report poor health. And then we looked at access, and we found huge differences by ethnicity, where actually South Asians were the ones to report the most barriers to accessing primary care. This is the ability to see a doctor for an urgent, non-emergent health problem. So you're sick, you need to be seen in the next few days, but you really don't need to go to the emergency room. Can you get in? And then we looked at, this is the same indicator by time since immigration. So there's a huge learning curve for learning the system. By the time people are in Canada for 10 years, the rates are fairly equivalent to Canadian-born. So maybe there's a lot we can do to improve access among newer immigrants just to facilitate access to the system in a whole host of ways. Language, I'm just going to skip all this. So, I know Ruth had asked me would I talk about aging, so I just threw in one or two aging slides from this, but we know that aging is, this is not the one. So I have a UK slide. There are now 10,000 centenarians in Britain, and it says this aging business is getting out of control. The Queen's practice of sending handwritten notes to people on their 100th birthday can hardly continue. So, but and we have, for those who are interested in aging, what we did, we produced a chapter on a report on older women's health. And what we did was we basically took all of our indicators and really focused on what did they show in the people over 65 and, kind of tell a story there. And then we added some new indicators about home care services and long-term care. So that's available on the web. But I just wanted to show this because part of it is how do you present data? So, we struggled a lot with, the tone of our report. We actually didn't write it for academics. We wrote our report mostly for decision makers across the health system and policy makers, as well as we wanted it accessible for community organizations and advocates. But what we did here was we used proportional width bars, because if we know that over 65, women are a higher proportion of the population. So if you only look at percents and not numbers, you could mask needs. So we use these variable width bars to show. So if you look at over 80, the number of people with 2 or more chronic conditions between men and women, it doesn't look that different. It's 74 versus 67%. But if you're doing health systems planning, you need to know how many people that is, right? So there's 150,000 women and 81,000 men. So we thought this was just an interesting way to kind of show the data that was helpful in making the case of what the numbers were and what the needs were. So basically, this is our bottom line, what we found. The social determinants of health influenced women and men differently, and that has implications, I think, for both public health and health system improvement. Many of the observed inequities result from chronic diseases and their risk factors. None of this is very surprising. But inequities in health status were much greater than inequities in access to quality of care, which shows that just fixing the health system is not enough. The need for a real, population health approach and the need to tackle the determinants of health. And inequities in screening and chronic disease management were greater than inequities in care for acute conditions. So the need to really focus on primary care in the community for some of these issues. And we found lots of differences in health status associated with ethnicity, but we really feel there's a huge opportunity to improve population health while reducing health inequities by focusing on chronic disease prevention and management and targeting at-risk populations. It's not rocket science, but somehow we don't do that. And reducing illness burden is key to health system sustainability as the population ages. Lots and gaps in what, we were opportunistic, we measured what we had data for. One of the limits is, with indicators is it's like looking for keys under the lamppost. We measured what we could, and there's huge holes in what we could measure. We developed a set of 27 leading health indicators, which again can be downloaded from our website, and they basically cover these domains: prevention and population health, access to care, cancer screening, chronic disease management, reproductive health, and the social determinants of health. And we think that these are really strategic indicators that are movable, that people could tackle, and that you could develop interventions and see if they're working. And our health equity roadmap basically came out with three, it's a 10-step roadmap, but it had three common themes. One was the need for integration and coordination, and not just integration within the health system, but integration between public health, healthcare, and social services. And then really the need for innovation and learning, that we need, we know what the problems are now, we have the data, but we need to fix them, and we need to move some of these indicators. But we really don't have evidence always, like what's the best way to do that. But that shouldn't be the barrier, I think, for intervention. What we should do is really, as we implement change, we should be rigorous and measure and learn what works and change course if it's not working. But I think there's huge opportunity. But that measurement and monitoring also needs to play a key role, and the really need to incorporate like gender inequity analysis as part of health system and population health performance monitoring. So I want some time for questions, so this is up on our website too, and I'm going to leave the slides here. But basically, we developed 10 points that kind of drills down into those themes that we think are actionable, from a policy level to develop a strategy in order to promote health equity in the province. So I'm just going to close with a Japanese proverb. Vision without action is daydreaming, and action without vision is a nightmare. So.